This is Stephanie Huff, and I'm recording another concept on perfusion. This one is on pulmonary embolism. So looking at the overview, pulmonary embolism is an obstruction of blood flow in the pulmonary vascular system. This could be caused by an embolus, which is a particle or aggregate of blood, fat, pathogens, or an air bubble. It could also be caused by a thromboemboli, which is an emboli created by a blood clot. Your other sources of emboli could come from tumors that had invaded the venous circulation, could be from fat or bone marrow, from fractures or other types of trauma, amniotic fluid release into the circulation during childbirth, or it could be IV injection of air or other foreign substance. It could also be from a DVT that was not recognized or treated. Your pulmonary embolism is a medical emergency. About 50% of the deaths from PEs will occur in the first 2 hours after immobilization. So looking at the pathophysiology, thrombi that only affects deep veins in the calf, immobilize to the pulmonary circulation. In a pulmonary embolism, you will have low alveolar oxygen pressure. The thrombi in popliteal iliofemoral veins can break loose and become an embolus. These embolus enter the pulmonary arterial system from the right side of the heart and eventually becomes lodged in a smaller arterial vessel. So basically it just kind of travels until it gets to a small vessel and becomes lodged there, and so it can't go any further. So basically everything after that, it will not be getting any blood supply. So the effects of a pulmonary embolism, an occlusion of a large artery can cause sudden death. Your gas exchange is going to be greatly reduced or prevented, and cardiac output falls dramatically as the blood fails to move throughout the pulmonary vascular system and return to the left side of the heart. For your lung tissue infarction, this is caused by an occlusion of a significant portion of the pulmonary blood flow. It is rare, less than 10% have this as a cause. Your obstruction of a small segment, this is of the pulmonary circulation with no permanent lung injury, and so basically it's just a small area. The body will reabsorb the clot and repair itself without any long-term damage. Your PEs will affect both perfusion and ventilation. You can also have chronic or recurrent and possibly multiple small emboli, and this will give them recurring symptoms. The dead space is areas of the lung that are not ventilated, but they are not being perfused, so they're not participating in gas exchange. And so this is kind of what I was talking about when that embolus lodges in those small vessels, and then no blood flow can get past that, so no oxygen is getting to that area of the brain. And then you can see in this picture how it shows an area of infarction, and so no blood flow is getting past that that clot where it's lodged in those arteries. Your fracture of your long bones, like your pelvis and femurs, can cause fat emboli, which is the most common cause of non-thrombotic pulmonary emboli. And so basically those fat seeds or fat emboli leak out from those bones, and they will travel up into the pulmonary vascular system. And so then that can cause them to have a PE. So a lot of times the goal is to immobilize those fractures early, go ahead and get them set, prevent them from bleeding, and making sure that they go ahead and get set very quickly so that the fat droplets don't leak out. Alright, so this is a picture just showing you how somebody can start off with a DVT and develop a pulmonary embolism from that. And so that's pretty common finding for a pulmonary embolism, is that it started out as a DVT. So etiology and risk factors. Thrombus from deep veins of the legs is the leading cause of your PE. Less common is fatty tissue from surgery or trauma like femur or pelvic fractures, but it's still a risk. Your risk factors, some of your risk factors are similar to those of DVT risk factors, and that's just because most of your PEs are caused by DVTs. So that'll be stasis of blood flow, vessel wall damage, altered blood coagulation, prolonged immobility, trauma, and that can be from hip, femur fractures, pelvic fractures. Alright, and so this is just another picture showing you how the DVT was in the upper leg and broke free, and so now the clot has moved up, and you can see that it has gone into the pulmonary vasculature from the right side of the heart. Alright, other risk factors are going to be surgeries, especially your orthopedic, pelvic surgeries, and gynecological surgeries, MIs and heart failure, obesity, advanced age, oral contraceptives or estrogen therapy, pregnancy and childbirth, kind of already talked about that, and inherited thrombophilias. Some of your cancers can produce coagulation factors that can put them at risk for PEs, and then cigarette smoking is also a risk factor. Clinical manifestations, they are going to depend on the size and the location of the emboli. Your small emboli, they may be asymptomatic. Your common manifestations and your symptoms usually appear abruptly. Dyspnea, pleuritic chest pain are your two probably most common findings of a PE. Anxiety, sense of impending doom is also common. May have a cough. Diaphoresis and hemoptysis or coughing up blood may develop. Massive PEs can cause syncope and cyanosis. On examination, so when you're doing your physical exam, you're going to see tachycardia, tachypnea, crackles, a cardiac gallop, so they may have a S3 and or S4. Fat emboli, characteristic symptoms of fat emboli are going to be sudden onset of cardiopulmonary and neurological symptoms. So they will have dyspnea, tachypnea, tachycardia, confusion, delirium, decreased level of consciousness, and petechiae may actually develop on their chest and arms. They may also have a low-grade fever. Collaboration. Prevention is the primary goal, so early ambulation of your medical and surgical patients to prevent venous stasis. The pneumatic compression devices after surgery and when anticoagulants are contraindicated. Other preventable measures are going to be elevating the legs, active and passive range of motion exercises, especially in the lower extremities. Your treatment is basically supportive, so give them supplemental oxygen to help with the dyspnea. Analgesics are given for severe pleuritic pain and also to help with anxiety. Your pulmonary pressures are going to be measured with a Swan-Ganz catheter, and they're going to be looking at the pulmonary artery and pulmonary artery wedge pressures. These are things that will be done and monitored in the ICU setting. and you'll learn more about your hemodynamic monitoring, which is part of your pulmonary pressures, next semester. Cardiac output should be assessed. The cardiac rhythm should be monitored to detect any dysrhythmias. Diagnostic tests that can be done. You've got your plasma D-dimer levels, and D-dimer is specific to the presence of thrombus, so if that's elevated, then it is highly suspicious that they will have a blood clot somewhere or a thrombus. Your chest CT with contrast. This is one of the principal tests to look at and diagnose APE. Lung scans, and this will include perfusion and ventilation scans. So a lot of times you may have like a VQ scan, and your VQ scans do take 45 minutes to like an hour and a half, because what they'll do is they'll take some x-rays and then they'll inject some contrast media, and then they'll wait a little bit and then redo some more x-rays looking for the pulmonary emboli. And so basically on your VQ scans, it is not resulted as a positive or negative. It is resulted as low probability, medium probability, or high probability of a PE. So you don't get a definite diagnosis on that. Pulmonary angiography is the definitive test when other tests fail to basically verify the presence of an emboli. Your chest x-ray may show some pulmonary infiltrates and effusions. Your ECG is to rule out an MI, because a lot of times their symptoms may be similar to those of an MI. Arterial blood gases is going to show hypoxia. Your end-tidal carbon dioxide is done to evaluate alveolar perfusion. Your coagulation studies are used to monitor response to therapies. So this is a CT scan showing you two different pulmonary emboli. And so on this arrow right here, you see this place right here is a PE, and then this one, they're showing you this big long piece right here is PE. So right through here. All right, pharmacologic therapy. Your anticoagulant therapy is standard in preventing a PE, but can also be given if somebody has a DVT or a PE to prevent further clotting and immobilization. So basically they will start them on heparin. They will give them a bolus of 5,000 to 10,000 units, and then they will start an infusion at about 1,000 to 1,500 units per hour. You need to make sure that you're monitoring your PTT frequently, because that's the test that goes with heparin. This drip will be continued for at least 5 days while they're waiting on the warfarin or your Coumadin to become fully effective. So a lot of times they'll start the warfarin at the same time as they do the heparin, because it does take about that 5 to 7 days for the warfarin to be therapeutic and fully effective in the body. So once it gets fully effective in the body, and they'll be checking your PT and INR levels for that, once they get therapeutic and where they're supposed to be, then they will discontinue the heparin drip. The warfarin therapy will be continued for 2 to 3 months when risk factors still exist for thromboembolism. Bleeding is always a risk for anticoagulant therapy. Your protamine sulfate is your antidote for heparin, and so it inactivates heparin and stops the bleeding. Vitamin K is used for Coumadin toxicity, and so it will treat the bleeding for somebody that's on Coumadin therapy, and so basically it is the antidote. Your fibrinolytic therapy is used to treat massive PEs and hypotension. Examples would be streptokinase, TPA, urokinase, and they are used to lyse or disintegrate the embolus and restore pulmonary blood flow and reduce pulmonary artery and right-sided heart pressures. There is an increased bleeding risk, especially cerebral bleeding. It is contraindicated in patients that have cranial disease, they've had a recent stroke, any active bleeding, if they have a bleeding disorder, if they're pregnant, if they have severe hypertension that puts them at risk for hemorrhagic stroke, and any recent surgery or trauma. So surgery is done when oral anticoagulant therapy fails or it is contraindicated. And so they can put in an umbrella-like filter and they insert it through the inferior vena cava. This is done in the cath lab. And this is done to trap large emboli while still allowing continued blood flow. The filter is inserted percutaneously in the femoral or jugular vein. And so these are a couple of pictures of your umbrella type filter. It's also known as a vena cava filter or a greenfield filter. And so this is basically what it looks like, and then this is where they put it in the inferior vena cava so it can actually trap those emboli and keep them from going into the pulmonary vascular system. So this is a very large emboli that was from the femoral vein, and they took it out from the main left and right pulmonary arteries. So this was a very large one that had to be removed. Alright, nursing process. Prevention, again, is going to be very important. So early ambulation after surgery or illnesses, compression stockings, and your PCDs, which are your pneumatic compression devices. You've also probably heard them as SCDs. You want to teach leg exercises so that they're constantly moving their lower extremities so that they're not getting venous stasis and pooling of blood. They need to stop every 1 to 2 hours during long travels and get up and walk around to prevent venous stasis pooling. Even if they're on an airplane, they need to get up and walk around for these long flights so that they don't develop PEs. We've had a lot of people come in that have either been on a long road trip or on a long flight that have come in with DVTs and PEs. So important for them to keep moving. Avoid crossing the legs. Walking and regular exercise will help decrease the risk. No pillows under the knees to prevent DVTs and PEs. And so a lot of this is the same kind of things that when we talked about DVTs, these are the same things that we did to prevent them as well. Alright, when you're looking at assessment, you want to get a good health history, assess their chest pain, their shortness of breath, ask them about history of recent surgeries, recent venous thrombosis, or if they've had DVTs in the past, their current medications, other risk factors, such as childbirth and malignancies. On the physical examination, you want to assess their level of consciousness. You want to assess vital signs, making sure you get an apical pulse and a temperature. You also want to assess skin color, temperature, and moisture of their skin. Assess breath and heart sounds. Check their oxygen saturation levels. Monitor for neck vein distension and peripheral edema. These are your NANDA nursing diagnosis. Alright, so planning goals may include that the client will have an oxygen saturation greater than 94%. They will verbalize fears that result from respiratory distress. They will obtain pain relief to allow adequate rest and comfort. They will exhibit adequate tissue perfusion, and their vital signs will remain within normal limits. So implementation in compensation for impaired gas exchange, you want to assess the respiratory status frequently. You also, when you're assessing their respiratory status, you want to include the rate, depth, effort, their lung sounds, and their oxygen saturation level. You want to place them in high Fowler or Fowler's position, and that will facilitate lung expansion. Monitor their arterial blood gas results to assess gas exchange and tissue oxygenation. Maintain them on bed rest. This will reduce the metabolic demands and tissue needs for oxygen. And this is just usually at the beginning stages of treatment of the PE. Alright, in preserving cardiac output, you want to auscultate heart sounds every 2 to 4 hours and report any abnormal findings to the healthcare provider. And basically you're listening for those S3 and S4 gallop rhythms. You want to assess skin color and temperature. This monitors their tissue perfusion. Monitor their cardiac rhythm for dysrhythmias, which can impair their cardiac output. Administer medications. Sometimes they may have to be put on vasopressors and other medications such as the anticoagulants, fibrinolytics if that was ordered, because remember they do have that risk for hypotension. And then you want to monitor the response to the medications. You want to monitor your pulmonary artery pressures, vein distension, peripheral edema. Heart failure is a complication of a PE, so you're kind of monitoring them for that. Maintain a good IV access, making sure that it's working at all times in case you do need to give them some medications quickly. Instructions on symptom reporting like chest pains. Promoting safety, you want to assess the signs of bleeding, so you're going to look at their gums, hematuria, so blood in their urine, looking to see if there's any occult blood in the stool or vomit. Are they having any incisional bleeding, bruising, bleeding from injection sites, joint pain? They could have bleeding in their joints, flank or abdominal pain. They could have bleeding in their abdomen or even in their kidneys. You want to keep the antidotes at bedside, so protamine sulfate, remember, for your heparin, vitamin K is for your Coumadin. Assess the medication regimen for any kind of interactions with other medications they were already taken. You want to avoid invasive procedures such as injections and venipuncture when possible, because they have that increased risk for bleeding. You want to maintain pressure on puncture and injection sites. They recommend firm pressure to help decrease the risk of bleeding in the tissues. And for arterial punctures, it's going to be at 30 minutes. Maintaining adequate fluid intake. You can give stool softeners as ordered to prevent constipation and straining that could cause bleeding hemorrhoids. Relieving anxiety. You want to assess the client's anxiety level. Stay with the client to help decrease their fears. Explain procedures and treatments. Use short, simple sentences. This will kind of decrease the fear of the unknown by keeping them up to date on what to expect. You want to reduce environmental stimuli using calm, reassuring manner. Encouraging family support to remain with the patient as much as possible. Administer morphine sulfate to help decrease pain and anxiety. For evaluation, your expected outcomes may include client maintains adequate tissue perfusion to promote oxygenation and healing. The client obtains pain relief to help facilitate rest and recovery. And the client will maintain an effective airway clearance. So this is the end of PEs. And as always, if you have questions, let me know and I will try to help clarify.